just like to start with some thank yous, specifically the Connections team. Let's give it up for them. All of the people behind the scenes that are making this happen are too numerous to list. I'll leave someone out. Thank you all for traveling all this way. You're passionate, or you wouldn't be here. And Jay and I are fueled by your participation and being here, and hopefully you'll leave here fueled and inspired. Well, I know we always are. So thank you all for being here with what I think is our biggest conference.
Yeah, I definitely think so. And you know, the thing that I like the most, and we talked about this in a chapter leaders meeting that was actually, I don't even know what day it is. It was Thursday. That you know, when we started this conference, we started the association. We definitely did not want this to be like other associations, because this is all about spreading the movement, and you are the movement. And so it's for me, it's the highlight is to have the buyers up here. We wish we had more buyers in the room, but we were talking to some folks about possibly getting more TPAs involved, more employers involved, more consultants involved as this movement spreads. There was too many people that stood right there at that lectern and said that, you know, I'm probably preaching to the choir. As we've said before, you know, when we think about, you know, maybe approving a consultant or a TPA or a vendor that maybe is on the bubble. And I would say, well, you know, you can't save souls until you get them in the pews. And so those are things that we're also trying to do some outreach for, to get more folks here in the room again, because, you know, as this movement spreads, we all win, right? We all achieve what we want. So anyway, I just wanted to share that real quick.
Well, it's ask us anything. Are there questions? And it's hard for us to see because of the lights. So we'll.
Yeah.
Any questions?
Hi, my name is Dr. Rod Story, DPC owner and physician in North Idaho. We're realizing that we're just one cog in the wheel, but we're so thankful to see so many people working in the same direction, but within their individual professional area of expertise, to develop a whole stream of alternate medical approaches to healthcare. It's very, very exciting to us, because we feel like sometimes we're very alone as just DPC clinic, and then we realize, boy, there's a lot of people making connections and creating something that we don't have to work with, we just have to partner with. One of the greatest challenges that we are running into is employers, and helping them wrap their head around leaving the traditional insurance model and jumping out. So my question for you two would be, what are some of the salient points that you would start that conversation with?
Well, that is, I heard somebody say great question. It is a great question. You know, our team, generally, when our phone rings, our perfect prospect is an employer that has gotten to a point, kind of like Drew Jacobs, which is, thank you, Drew, you did an amazing job both sessions, holy cow. But usually they call us and they're a little pissed. They don't know who to be pissed at yet, but we help them with that. But and so, you know, just walking into an employer that is still kind of asleep, it's going to be a harder discussion. I mean, they if they don't necessarily perceive that something's wrong. I mean, costs going up, benefits are going down. Obviously, that's wrong. But if they just kind of view that as, well, that's just all there is. That's just the way it is, and they haven't reached that time where they're ready to be awakened, it is more difficult. For that employer that is still asleep, what you do, I mean, it's just the fundamentals. I mean, you come in and you're going to have to start to talk to them about how an integrated health systems referral chain raises their costs and lowers their quality. You're going to have to start comparing free market facilities, all in complete bundled prices for certain surgeries with other surgeries that they may know what they paid for. That also becomes a little difficult though, because the employers, a lot of times they don't know what individual claims cost unless it's for them or a family member. If somebody just had their knee replaced on an Aetna plan and they pull out their EOB, and you could go to, Wellbridge Surgical or Surgery Center of Oklahoma or any of the other hundreds of facilities that do that. So, this is what you could have paid. And maybe that'll start to open their eye.
Yeah, I would agree with that. If to approach somebody who doesn't even realize they ought to have sticker shock is like pushing on a string. And you could just say, here's my card. When you get pissed, call me.
That's right.
Just keep the conversation short.
Yep.
The more you talk, the more you sound like you're in sales. I was in a meeting with a big energy company in Oklahoma City, and they were talking, you were there too. They were talking to us like we were vendors, like we were trying to sell them something. It's disgusting. No, I mean, we want to partner with you
We can help you.
We can help you, and we want to partner with you to help you. But it was this, like they were treating us like we were salesmen. And if they ever come back to the table, they will come to my office or they'll come to your office. We'll never go down there again.
Agreed.
But I mean, if they don't even know they have sticker shock, then tease them with something provocative and leave your card and walk away.
Yeah, there's, like in the Bible with the white harvest fields, don't go pulling on green stalks.
Yeah, great question. Yes.
Hello, my name's Jimmy Hawks. I own a DPC in Las Vegas, and I appreciate the conference very much. I've gotten a lot of ideas and things to take back home. So my next question is, can we have the next conference in Las Vegas?
Everything is on the table.
Yeah, we're a few sponsors short, I think, of affording Las Vegas. This FMMA is not a revenue generator for Jay and I and our families. So yeah, but sure. Yeah, we'll put it on the list.
Hi, 2 questions. The first is related to your breakout session yesterday, Dr. Smith, with regards to Atlas and how you mentioned that hospitals who were trying to drive you out of business at the Oklahoma Surgery Center were now, trying to bundle their prices and use Atlas, which I'm guessing, we're at this conference, so it facilitates cash pay. So I'm curious to one, given their initial resistance, what made them start using Atlas and start playing nice with you? And then secondarily, with regards to self-funded plans or self-insured employers, how are they able to utilize cash pay? I've heard a lot about DPC and maybe pass-through pharmacies and labs and things like that. Just curious to kind of tease out more around how that enables, I guess, a free market, just because in my mind it still is insurance. So, it still seems to me a little different than what I consider a free market.
Yeah, so for the Atlas question, great question. She's referring to yesterday in the breakout session, Greg Smith and I talked about how Atlas and Coral work together. And I made the comment that it's very ironic that the very hospitals that tried to put Surgery Center of Oklahoma out of business are now vendors of Atlas. I mean, when a client of Jay's or Boone Chapman or anybody else reaches out and says, we send you all these cases, but we've got this person that needs a thoracotomy. We've got this person that has a pituitary tumor. They need a colon resection. What do you got? Well, we can't do that in an outpatient center. So I know who the good surgeons are, kind of know where they work to do their inpatient cases. So I'll reach out to the hospital, get the CFO on the phone and say, listen, this is somebody who lives in Orlando or Austin or Madison, Wisconsin. He's not a patient you would ever otherwise see. How much for a colectomy? And the prices they give us are astounding. I mean, it's just almost without exception, astonishingly low. Then Kylie Mays, who helps me run Atlas, we put a bundle together that includes that hospital price, come back to the buyer, the self-funded employer, and they say, yes, all day long, we'll buy it at that price. So I just made the comment that it's ironic. I mean, these same hospitals that spent real money lobbying to put Surgery Center of Oklahoma out of business in various diabolical ways, they're now we pay them, we work with them. And so astonishingly, the attacks have stopped, because they have an income stream that is a result of this free market movement. The second part of your question, the best way to think about self-funding as a cash buyer is to understand what my friend Marty McCary has always said, the concept of a proxy buyer. So the self-funded plan is not the employer's money. I mean, once the money goes to the plan, it is for the benefit of the employees and the beneficiaries. It's not the employer's money anymore. The employer's on the hook, but it's technically, legally not their money. So it is actually the employee's money that's being spent. So they are a cash buyer. Their proxy is the employer, and because it's a large plan, many times they have economies of scale and they can get better deals. So Jay figured out a way to make our exchanges look like a cash buyer, and so I don't distinguish them really.
Yeah, so I'll add on to the second part of the question. The how we were able to configure our employers' plans to look like cash is very simple. It's just through very simple plan design, or an insurance speak policy design. Most everybody is aware in the status quo world or in the fully insured world, you have out-of-network benefits and you have in-network benefits that are a little better. We simply created another tier within the benefit plan that we call it our premier tier. None other that is higher, and that tier simply is not subject to the plan's deductible or coinsurance, and so it's just 100% benefit, very similar to like some of the ACA mandated benefits. So that's how we mechanically do it. But to add on, I can tell you any self-funded employer in the room, they can certainly attest that this is not insurance, because they do not take their funds and then send them to the Kempton Group or any insurance company. There is no transfer of risk. The risk is still retained 100% by the employer when they're self-insured. When you're fully insured, that risk is 100% transferred to the insurance company, and you're paying for that risk transfer. So yeah, Taylor, I can see you. I can't see many other, but you definitely understand that, because you see the invoices that come through, and they are paid directly out of Pitlick and Wick's revenues. I'm a clerical service. I get paid to pay claims, but I don't have any money of my own.
Is that Clint?
Maybe.
Depends on the question, right?
Yes, it is. I'm Dr. Clint Flanagan. I'm a physician. I've been a doctor for over 20 years in Colorado, and we started Colorado's first DPC over a decade ago at a time where there were only a few of us. First off, I just want to say thank you, Keith and Jay, for putting this together. It's great to be in real life again, and I can't tell you how much I appreciate everyone that's here and the energy. We need these types of things happening to help change from the status quo. I'd like to comment specifically on the prior comment with regards to it still kind of seems like insurance. So having been a physician that has worked insurance for many years, actually I would say a recovered fee-for-service physician that also has billed insurance, that also has owned clinics that are fee-for-service clinics. One of the main reasons we moved into direct primary care, which at the time we didn't even know what that was, we just called it monthly membership medicine, pay us a fee, i.e. free market, pay you, the consumer, patient, pay the doctor a fee, unlimited care for that month for one simple fee. That eventually turned into the word DPC, but it's very much free market because the consumer, the patient, pays you, and technically our contracts are month to month. So if they don't like it, they could go to the next doctor. So very much it's the patient in control, and you, the physician and or healthcare team, need to provide some value there. And so by allowing that to take place, it allows the physician to provide the level of care and practice within their scope that they can do because they don't spend a third to a half of their day having to keystroke their computer to meet some quality metric or to have to submit a bill to United, Anthem, or Aetna. That is a model that is far from free market that I don't know any physician in America ever wrote about in their med school essay. I want to be a biller and coder and waste time away from my patient. The next piece of this is a lot of what Keith and Jay are doing, and that is transparency on pricing. And when it comes to insurance, good luck finding transparency. They make it unbelievably complex. And then they put things like prior auths in front of things to make it even more complex. This is very much a free market lane where your physician is obviously wanting to provide really good health care for you and your family and do no harm. But the second thing the physician is doing is wanting to do no harm to your pocketbook. Because many of us are in the know and we're aware of the fact that if you're using your insurance card in the traditional sense and fully insured plans to pay for a vasectomy or your medication or colonoscopy, et cetera, that cost and price can be very different. So the free market fortunately wins in a tremendous way here that you have a navigator like the kind employer gentleman spoke about earlier in his heartburn medication, helping you navigate. And so we are about the farthest thing from insurance purposefully. Thank you.
Thanks, Clint.
Hello, Steve Kriebel. I'm a pediatric ER doctor and then an independent contractor in ERs pretty much in Texas. And so I've been doing this for about 25 years, been in practice over 30. So it's very different. I'm going to have to give a very different story than everyone is talking about their DPCs. And for me, I'm just trying to learn the language. So this conference has allowed me to be exposed to the language, begin learning the language. And then what I've told some of the speakers is that before it was just ethereal. But now I can see there's a puzzle that you can put together.
We actually had a request our first year that we create a dictionary of all of the three-letter whatevers. I don't think we ever did.
Yeah, I think it is.
We did.
Well, I think it's
Yeah,
geek
there's
speak.
one on every table,
Yeah, you
and
got
there's another version that's on the FMMA website that's a little older.
So it's prescient, but for me now I can see the pieces of the puzzle. It's just now how do you put those pieces of the puzzle together in the most efficient way, in the most true cookie cutter way that makes it as efficient for me to do that and have confidence in it. That's number one. Number two, then, I'm 60 years old, and so I've missed out on a lot of the free market philosophy because the way I came out, my maturity was only coming into the year before an ER group that was an independent physician group in the hospital. But the next year, I came on with the physician network, which was then associated with within the umbrella of the system, right? And then that physician network was taken over essentially by cronies that were put into positions of power that then did not really work for the physician. They were working for the system, what was best for them. So I understand I went down a very bad road. And that's my own choice, and I never exposed myself to anything else, but that's the way I was trained. That's the way I grew as a professional. So how do we, first of all, selfishly, I need more. So this conference is the beginning, and I've made some relationships, and I'll follow up with them, but I think we really need to focus on the people that have come here that really need that extra help and just being at a conference, because we know there's an attrition rate that some are, because you still fear going to something new, that we follow up with them, number one, and make sure their needs have been met by this conference. The second is then how do you continue to reach those people who have not heard? And for me as a physician, and I love to teach, then how do I then present this to the medical students I teach and the residents I teach, when I know it's going to be like they're looking at a doctor with three heads when I tell them something that is related to the free market, and you can do something different than what you've been experienced when they haven't really done any coding or billing. They don't even know about that. They're not taught on that. So,
You can have them join the BRI Institute.
okay.
Yeah, and there's a lot in your question. Keep in mind, it took 5 years and probably 11 failed attempts to open Surgery Center of Oklahoma. So it's hard. I mean, and what is my path? What is your path? Your path is probably different from mine. It's probably different than Clint's or Dr. Imes or anybody else in this room. The key is to acknowledge your leverage and acknowledge your fears. And if you're 60, you look young and healthy. You probably live to be 90 or more. So you've got another career ahead of you. The way I think, and I think some of the medical students are still here, I think what they're inspired by is not all this. It's action. It's what are you doing? Because otherwise it's this. So the way to inspire young people, I think, is to do and is to act. And that means to face our leverage and fears head on and decide, I just am going to decide that the benefit is greater than the risk and go for it. There are physician-owned emergency room hospitals that are out there. There's two in Oklahoma. There's one in Oklahoma City and one in Tulsa. There's several in Texas. This whole idea of a freestanding emergency room hospital is real. This is not proof of concept stage anymore. I mean, we are way past that. So how do you put it together and make it work? There are models out there that are functioning and have been functioning for quite some time. So how do you plug that in your own market is a very distinctive sort of problem that may or may not be like the challenges that I face for sure.
I appreciate it. Thank you.
You're welcome.
It's certainly not there's not one cookbook answer for anything in this movement. There's things that work and there's things that don't work, but the thing that works that nobody knows about, that is yet to be invented, that's out there in spades. We hear, we're learning all the time as well.
And I wonder if the way we spread the word more is to have our enemies do it for us. Maybe we should be more provocative so that even the enemies are talking about us. So
We're doing a pretty good job of that, but we could always improve.
Yes.
Ray Cordnoy, internal medicine. I'm a membership doctor, DPC, concierge, but DPC. I wanted to follow up on Keith's reply to the prior question. I've had students come to me now. They find us and they want to spend time with us and shadow us. So to the physician that's educating other medical students, let them know that they just go to the DPC Frontier Mapper and they can find doctors. I'm happy to mentor anybody that wants to come and spend time with me. I've done it many, many times. And that's when I show them how a practice works. And they love it. They're already planning their residency around getting out into private medicine.
That's awesome. Yes.
Hi. I'm wondering, do you have any suggestions in terms of an all-around healthcare plan or setup for, say, medical students or just in general for individuals who do not have an employer who contributes to their healthcare costs or their insurance, but is still required to have a certain type or standard of coverage? In case you weren't already convinced that the market is very broken and the system is broken, and if you need a good cringe, you should know medical students pay $450 a month at Oklahoma University for health insurance.
I was gonna say, I think
Most
they're
of
still
us
here.
are pretty young and healthy.
Yeah.
They're waving their arms right
There you
here.
go.
All right, I'll come find you.
Christian Healthcare Ministry. So we're a medical cost sharing ministry. We work outside of the insurance mold. We deal with individuals, and you have free choice.
Paired
That's
with the DPC.
Yes. We're working on that. Yes.
So I think the trouble that we run into is that places like OU and some places, they will not accept that as the standard of coverage. So I know some students have tried to break out of the BUCA, big mold, $450 a month. And, of course, they pose it as this is such an affordable, high-quality plan, and it's garbage. And so how do you work with the administrators of schools, or like I said, just any individuals who are required to have certain coverage to satisfy them that this will be adequate health coverage for those people?
Generally, just as an overview, we provide a letter that shows that the federal government sees us as an affordable and acceptable alternative to traditional health insurance. If that doesn't work, as the CFO, I'm happy to connect with whoever I need to connect with.
Thank you so much.
Of course, my gut level answer is it's none of their damn business. I'm self-insuring.
So, guys, we've talked, and I think Zach said it well. We're preaching to the converted, but I think I want to know what your opinion is of the best way to reach out to the non-educated, non-informed. We talk about employers, we talk about physicians, we talk about people. How do we reach out to the ordinary masses to get them converting? And is there a way for us to, is it reach out to our congressman? Is it reach out to, where else can we go with this movement?
I think there's a lot of answers to that. Again, the sharing ministries are a great vehicle because, they start to realign the market forces. The patients see the cost. They see that they're sharing it with their neighbors. They become price sensitive and price aware. Employer plans, especially self-insured employer plans, if they're designed right, they also allow visibility into those for those employees and those dependents about price and the differences and being able to discern value. And they talk. They talk to their families, they talk to their friends, and they share it. Just honestly, Bill, I think your point is well taken, and it would be great. But I'm a pretty good sales guy. But if I was to say, hey, come to a town hall meeting and learn about free market healthcare, it would probably be just me and Keith. Yeah. And so, people, this is just not on their radar until it's on their radar.
We had a conversation with the chapter leaders meeting. How do we promote this? How do we pour gas on this movement and make it more visible? My thoughts on that is content. And I'm here to tell you, for not much money, you can have a YouTube channel. You can buy the stuff and make your own videos. Everybody in here has stories and content, and put it out there and tell these stories. And stories about people's lives are transformed or saved. Steve Lantier was telling us about it the other day about a Canadian we operated on that was in a 3-year waiting list for a hysterectomy, and she was tired of getting transfusions. So we saved her. And it's $8,000 all in. Those kind of stories are powerful, and everybody in here can go buy a Canon video camera and make 2-minute videos and figure out a way to get that information out there? And I think the answer is content. And I think it's patient stories. And then even more so in the industry, the radical, insane savings on individual procedures and how an employer is able to richen the benefit plan or give his
All the while
employees
decreasing
raises.
costs.
Yeah, I mean, all that stuff is powerful. So it's on all of us, I think, to just burp out as much content as we possibly can, and then the world will take more notice.
And early on, we were able to get the attention. I don't know that we really care anymore, but we were able to get the attention of some of the local news stations in Oklahoma City. And I was surprised by, we're not trying to figure out how to get on the news, but you might want to call your local TV station and say, "Hey, I've got a public interest story." You're not going to say, "Hey, I want to talk to you about free market healthcare." I got a public interest story about how a patient saved a ton of money, or like Keith's story about the Canadian with the waiting list with the hysterectomy. Those are those personal interest stories that I don't know a local newsroom that's not looking for that kind of content. And if you get their ear and they come out, you can spin it the way you think would be most beneficial. And we've learned, Keith has actually taught me, when you're in front of a reporter, if that's the route you go, you certainly don't answer the questions that they're asking. You answer the questions that you wish they asked.
I think we're out of time. Thank you all for being here. We will see you next year, and when we figure out where it is, we'll let you know.
Absolutely. Thank you all so much.
Thank you all.